You're listening to the lecture on assessment and management of patients with hepatic disorders. The objectives for this lecture are for you to be able to identify the metabolic functions of the liver, as well as alterations that occur with hepatic disorders, explain liver function tests and the clinical manifestations of liver dysfunction in relation to the pathophysiologic alterations of the liver, relate jaundice, portal hypertension, ascites, varices, nutritional deficiencies, and hepatic encephalopathy and coma to the pathophysiologic alterations of the liver. Describe medical, surgical, and nursing management of patients with esophageal varices. Compare the various types of hepatitis as well as their causes, prevention, clinical manifestations, management and prognosis, and their home health needs. Use the nursing process as a framework for care of a patient with cirrhosis, and identify medical management of patients with liver cancer. The liver is complex, and when dysfunction is present, it can affect multiple body systems. Liver disorders are common, and so the nurse needs to be able to identify as well as understand the clinical manifestations, as well as the treatments for the different disorders. So if you are not familiar or don't remember the A&P of the liver and the biliary system, you definitely want to go back and review that. And these are in your slide. They're in your book. There's also an A&P section in your book that is a good review as well. These are the different functions of the liver. Gluconeogenesis is the process that the liver uses to take amino acids from protein or lactate and then turn that into glucose. So, and if you're looking at the amino conversion and the byproduct is urea, whenever we talked about the kidneys, we were looking at the BUN or the blood urea nitrogen levels, and that is what they're talking about. So that's where they get that from. Bile is formed in the hepatocytes and is sent to the gallbladder to be stored until it is needed for digestion. So when you eat, then the gallbladder will release some bile, and that helps to break down the nutrients and get them absorbed. Bile salts are synthesized from cholesterol. Liver dysfunction can lead to a deficiency of vitamin A, K, C, folic acid, thiamine, riboflavin, and pyridoxine. So you need to make sure that you're checking those levels as well, especially if you do have liver dysfunction, because that's where a lot of those nutrients can get absorbed. And it's because of the bile and the bile salts being excreted. There are different liver function studies. The AST is elevated with the death of tissue in the heart, liver, skeletal muscle, and kidney. So it isn't necessarily specific to the liver, but it does help to identify that there is tissue damage. The ALT increases in liver disorders, and it's used to monitor the course of a disorder. So if a patient is diagnosed with a liver dysfunction, then they can check the ALTs, and they might be slightly elevated and then become more elevated as the liver disease progresses. So it is used more to identify a progression in a dysfunction instead of identifying a specific dysfunction. The GGT and GGTP will be increased with cholestasis as well as alcoholic liver disease. The LDH is your bad cholesterol. They can do bilirubin tests, and it identifies the liver's ability to conjugate and excrete the bilirubin. Protein studies are done to see if the liver is able to manufacture and break down different specific proteins. And then they check clotting factors because these are prolonged. If you have liver failure, because the liver is where you get a lot of your clotting factors that are produced. Biopsies can be performed when lab tests are not diagnostic. So if they're not able to identify a specific disease based on the lab values, they will do a biopsy. Peritonitis is a common complication of a biopsy because blood or bile can seep out into the peritoneal cavity whenever they do a biopsy. So that's something that you would need to monitor for after they have the procedure. They can also do an ultrasound, a CAT scan, and an MRI, and this helps to identify the size of the liver. It can be used to identify blood flow or see if there's any kind of blockage of blood flow. And it can also look at fibrosis or obstructions. Hepatic dysfunction can be acute or chronic. And we're going to talk about cirrhosis of the liver. We're going to talk about alcohol use and abuse, infection, and then there's liver diseases that are fatty liver, and they can be from alcohol or not from alcohol. Okay. In general, if you have a patient who has a hepatic dysfunction, they will present with jaundice, portal hypertension, ascites. They can have hepatic encephalopathy, and they'll have nutritional deficiencies, and we'll talk more about those. Okay. So jaundice occurs when the bilirubin becomes increased, and they have excessive destruction of red blood cells or an obstructed bile flow, and so the bilirubin actually spills into the serum blood. If the patient has hepatocellular or obstructive jaundice, then you're going to see these signs and symptoms, and they are a little bit different. So if you have a patient who has jaundice, they can see if it's obstructive or if it's more hepatic based on how they're presenting. Portal hypertension is when there's an obstruction of blood flow that is actually supposed to go through the liver. You have increased pressure throughout the portal venous system, and so they'll have portal hypertension. They see it a lot with patients who have cirrhosis, and the increased pressure can also can cause damage to the spleen, and they might see splenomegaly. They can also get esophageal varices, and we'll talk about that a little bit later. As far as ascites goes, and that's the fluid in the peritoneal cavity, no one can really identify the actual pathophysiology of ascites, but they do have different ideas and different theories about it, and they're all mentioned in the slide below. But no matter what the initiation or initial cause of ascites, it turns into a perpetual cycle of imbalance with the body attempting to compensate because of the imbalance, and then more fluid is built up in the abdominal cavity, so the body tries to compensate for that, and it actually produces more fluid. So it's just like if you have edema and your body's trying to compensate. Whenever you have a patient with ascites, you do need to check their abdominal girth. They will present with shortness of breath, though they can complain of abdominal discomfort. They complain that their just abdomen feels really tight and full. You'll want to look for fluid and electrolyte imbalance. Ask them about their bowel movements, ask them about their diet. And then again, check their abdominal girth, and it will be done daily. So you'll get daily abdominal girth assessments, and then you'll also get daily weights. They will be put on a low sodium diet to kind of help with the fluid retention, and you need to let your patients know that it can take several months for their taste buds to adjust to unsalted foods, especially if they salt everything. They need to watch their salt substitutes because some salt substitutes contain ammonia, others contain potassium, and so they could be trading in one problem for another. Generally, use of dietary modification along with diuretic use is successful in 90% of the patients who have ascites in decreasing their ascites. Most of the time, the doctors will do the low sodium diet with the aldactone. They can use furosemide but if you do use Lasix, you need to watch those electrolyte levels and make sure that the potassium is not depleted. They can do a paracentesis to get rid of the fluid. They can do it as diagnostic if they're trying to figure out exactly what's causing it, and they can also do it as treatment. The TIPS procedure is a cannula that is threaded into the portal vein, and then they insert a stent. If paracentesis is not successful and the patient can be given IV albumin and that's not effective, or for some reason those two methods are contraindicated, they can do the TIPS procedure, but it does come with complications. Patients can also get esophageal varices. So whenever you do an assessment, you need to get a good history on alcohol use and abuse, both current and historical. Assess their level of consciousness, make sure that they're alert and oriented. Assess their skin. Is it warm or cool? Does it feel damp? So do they have cool, clammy skin? Check for hypotension and tachycardia. Those are all signs that they have some sort of hemorrhage and hypovolemia. You can get a CAT scan. They can do angiography, ultrasound, and endoscopy to diagnose the varices. They can also do the endoscopy as part of a procedure to treat. So with esophageal varices, the varices form, and then over time, they actually increase in size. Eventually, they can rupture, and then this will cause hemorrhage. It is a life-threatening condition because of the hemorrhage as well as the location, and they'll go into hemorrhagic shock pretty quickly. So treatment, they will be admitted to the ICU. They'll determine the extent of the bleeding. As a nurse, you want to monitor their vital signs. They can, depending on where at in the esophagus the bleeding is occurring, they can vomit up blood or they can actually cough up blood. You'll do IV fluid replacement for hypovolemia. They can get volume expanders as well, electrolyte replacement. They might need a transfusion if the bleeding is excessive. Non-surgical treatment is preferable to surgical treatment because the surgical treatment has a high mortality rate. If the patient is on vasopressin, you want to stop anything. You want to stop that, and then if they have coronary artery disease, you don't want to give them a vasopressor, even though you might give it to someone that is bleeding. So make sure you get a good history. Beta blockers can be prescribed after they stop the initial bleeding event, and that can help prevent rebleeding. They can do endoscopic sclerotherapy, which is the sclerosing agent being injected into the vessel adjacent to the varices, and it causes it to harden and scar and slow or stop the bleeding. They can also do the endoscopic variceal ligation, and that's when they have a rubber band that's placed over the varices. It cuts off the circulation and stops the potential for bleeding. They can also do TIPS, but again, that's only done if other therapies that are more conservative or have less complications are not successful or they're contraindicated. And surgical treatment is the last resort. There's different places and types of shunts, but if they need to do portal systemic shunts due to obstructions, they can do that, and that will reduce the portal hypertension. Make sure that if you have a patient who went through any of the procedures or through surgery, you need to make sure that they're safe. Monitor their level of consciousness post-procedure or post-op. Monitor their vital signs closely. Monitor nutritional status. They can have an NG tube if they have nausea and vomiting because you don't want to irritate the varices and cause them to bleed again. And the acidity and just the forcefulness of the vomiting can cause the bleeding to restart. They will be NPO. You will start parenteral nutrition so that you can give the esophagus rest and time to heal. You can also give blood transfusions if needed, and you can administer vitamin K, which will help with clotting. They need to be put in a low stimulus environment so that they can rest. Hepatic encephalopathy is a life-threatening complication of liver failure. The initial onset of symptoms are subtle and then they'll progressively get worse. Increased ammonia levels are what starts or exacerbates the encephalopathy. The ammonia stimulates gamma aminobutyric acid neurotransmission, and this will cause CNS depression. It will inhibit neurotransmission and synaptic regulation, and this results in the patient having sleep and behavior disturbances. And the patients can have seizures, so you want to put them on seizure precautions. Fetor hepaticus is a sweet fecal odor on the breath. Whenever the patient talks, you might smell that sweet, breathy kind of smell. They can slip into a coma if the ammonia levels get too high. They can also be irritable and aggressive, and so they might need to be restrained. They might need to have a sitter so that they don't harm themselves and they don't harm someone else. Because they can pull at NG tubes, they can pull their IVs out. They can have reversal of day-night sleep patterns, so where they want to sleep during the day and then they try and be up all night. They'll get drowsy, again, disoriented. Their behavior will become inappropriate, so they might do things and say things that they normally wouldn't do or say. They can have mood swings where they're happy one minute, sad the next, and then they go to irritable. They're easily agitated and they're very, very confused. Then once you get through that, if their ammonia levels still continues to rise, their speech will be incoherent. Then they can slip into stupor and coma, and eventually they will not respond to painful stimuli. Lactulose can be given to decrease the ammonia levels, and it pulls the ammonia out through the GI tract. It can cause cramping, bloating, and loose stools, so you do need to monitor the number of stools, consistency of stools. It can be given via NG tube. It can also be given via an enema. And then if they're able to swallow and willing to take it, it can be given orally as well. It's like a really thick syrup, and it's super, super sweet. During the hepatic encephalopathy, you want to monitor for patient and staff safety. You'll get daily ammonia levels to make sure that the levels are going down and they're not rising. You'll check fluid and electrolyte balance, especially if the lactulose causes loose stools. You can give them like D5 water, G5 normal saline through the IV, and that will help keep the sugar in the body for metabolism. And make sure that you teach the patients about lactulose use because they will most likely have to go home on lactulose to keep those ammonia levels down. They'll also have to get random ammonia levels checked whenever they're at home. They're at increased risk for falls whenever they're confused, so you need to make sure that they are put on fall precautions. Monitor for signs and symptoms of hypovolemia. They will probably be on dietary restrictions and they need to be educated on that. And then talk to the family members about subtle changes that you might note that they might notice in their behavior that they can report before they get to the point where the ammonia levels are really high. Hepatitis, there's different types of hepatitis. Most of it is viral, but it can be non-viral as well. And we'll go over the different types. There's hepatitis A, B, and C we've heard of all the time. You hear about that and you can get hepatitis B vaccines, hepatitis A vaccines. Hepatitis D and E we don't hear of as often. Hepatitis D you get if you have B. So it's not something that you'll get all on its own. They usually have B first and then they get D. And then they get D. Okay. This chart comes from your book and it shows the different types of hepatitis as well as the causes, which is pretty easy. It's the A virus, B virus, C, D, E. Easy to kind of remember. Signs and symptoms. Most of the time you really won't have symptoms. until you are later on in the stages of the virus, or you'll have vague symptoms. So serum blood testing, if you are at high risk or think you've been exposed, is best to do early on. And then the different outcomes, depending on when you seek treatment, if you can get treatment, depends really on the outcome. So hepatitis A is seen more in countries with overcrowding and poor sanitation. It can be transmitted through sexual activity, um, but it's known, and you'll see it in the news as spread from poor hand hygiene. People that are at restaurants, fast food restaurants, or sit-down restaurants, cafeterias, and they don't wash their hands and they go to the bathroom and they transmit it because it is the fecal oral route. Most people will recover from hepatitis A, so they'll have their symptoms. The virus will run its course, they'll treat the symptoms, and then they'll actually start to feel better. Treatment occurs in the home generally, unless the symptoms are severe and they need to be hospitalized because it is viral. It is basically treating the symptoms until the body can recover or the virus runs its course. Treatment basically focuses on education and symptom management. Education so that you don't spread the infection, and then also this is how you could have received the infection. And it's good to try and trace back to see if they obtained it because they went out to eat somewhere, trying to find exactly where they ate. So where could that have transmission occurred? Generally, they'll be put on bed rest so that they can have that energy. There'll be a low stimulus environment, and that's so that the body can do what it needs to do to fight off the infection. They need to get the vaccine if they haven't had the vaccine, so they'll be educated on that. If they have children, the children need to be vaccinated if they are not vaccinated already. If they go travel, especially overseas, illegal drug users and those with multiple partners also need to get the vaccine. And then anyone, even if you don't have multiple users, if you do have the oral, because it's an oral fecal route, if you have any kind of sexual activity that's anal, you want to make sure that you get vaccinated just to be safe. Hepatitis B can be transmitted through blood or bodily fluids. It is mostly sexually transmitted disease, but it can be transmitted maternal infant as well. And this is during birth. As far as management, education, avoid high-risk behaviors, avoid multi-dose vials in patient care situations. They notice hepatitis B can be transmitted in healthcare if they are reusing syringes, the multi-dose vials going in and out, if they don't clean the devices properly. And I want to say, I know Las Vegas was one and Miami was another place where they weren't cleaning. They're giving colonoscopies to veterans and they weren't cleaning the equipment properly. And there was a huge ordeal about potential contamination, cross-contamination, and spread because there was blood and bodily fluids that remained on some of the equipment because they weren't disinfecting and sanitizing the way that they should have. They can be vaccinated. Healthcare workers are required to have the hepatitis B vaccine, and it's a series of 3. If you could have international travel, those patients or those clients should be vaccinated for hepatitis B. If they have multiple sexual partners, if they're considered high risk based on their job or their activities, they should receive the vaccine. Hepatitis C is mainly transmitted by blood transfusions as well as sexual contact, although blood transfusions is not as common now because they do a lot of screenings. As far as management, you can give antiviral medications. If they are drinking alcohol, then they need to stop drinking alcohol. And again, education is the big thing. They need to be educated on prevention. Hepatitis D, again, only People that have hepatitis B are at risk for hepatitis D. And hepatitis E is not something that you see a whole lot, but it is fecal oral, just like hepatitis A. And it can also be transmitted if water is contaminated with the feces by someone who has hepatitis E. So education, good hand hygiene, hand washing would be the prevention. As far as hepatic cirrhosis, alcoholic cirrhosis is the most common type of cirrhosis. Post-necrotic cirrhosis can be caused by acute viral hepatitis, and so it can be in someone who does not drink alcohol and they still have cirrhosis. They can get biliary cirrhosis, which results from chronic biliary obstructions and infection. However, this is not common at all. With cirrhosis, the liver will become enlarged, and the enlargement of the liver causes pain. The liver, if you palpate the area above the liver, you'll notice that the liver is firm. There will be a sharp edge that can be felt on palpation. Be careful when you palpate though, because it can be painful. If a patient has cirrhosis, some of the late signs of cirrhosis would be ascites and portal hypertension, and portal obstruction, and that's due to the swelling and liver enlargement, but that again would be later on. Hopefully you catch the cirrhosis before it gets to the point where there's permanent liver damage. Chronic gastritis and impaired GI function and impaired liver function will cause anemia and vitamin deficiency, and so these patients are at very high risk for malnutrition and need to be evaluated and treated for that, and then have the vitamin and mineral supplements. Treatment is based on symptoms. Again, vitamin, nutritional supplements, including vitamin and minerals. They can be put on diuretics, especially if they have ascites, and they can be put on H2 antagonists if they're having GI upset and GI symptoms. You will do daily weights, daily measurement of abdominal girth, and then monitor their intake and output. Patients with cirrhosis, you're also going to look at their magnesium levels, and you're going to look at bleeding time most likely to make sure that they still have good clotting factors that are working and being produced. You can look at liver enzymes, and you'll monitor their electrolyte imbalance. Promote rest, make sure that they are well hydrated, make sure that because they're going to be weak, that you have someone with them whenever they're getting out of bed, help them with their activities of daily living, and then try and plan the activities so that they have periods of activity followed by periods of rest. That way they don't overexert themselves. As far as improving nutritional status, again, vitamin, mineral supplement, and find out what they're deficient in and then replace that if possible. Talk to the patient about what they want to eat. If they do consume alcohol outside of the hospital, then you're going to want to watch for signs and symptoms of withdrawal, so you'll really need to monitor their blood pressure. Make sure they don't have complications of withdrawal. Look for hepatic encephalopathy as well, because they're not able to break down and excrete the ammonia. They can have the hepatic encephalopathy. Look at their skin. They do need to rest, but you don't want to cause any kind of skin breakdown. Their skin generally is itchy, especially with jaundice, and you want to make sure that they're not scratching at their skin. You can put lotion on their skin, so whenever they do feel itchy or their skin looks dry, you can have them apply lotion. The rubbing of the lotion feels good, can relieve some of the symptoms, and it can also rehydrate their skin. And there are different complications. We talked about hepatic encephalopathy, fluid volume excess, the ascites, and then they can have bleeding or hemorrhage. And so all of those need to be watched for. As far as cancer of the liver, hepatic tumors can be malignant or they can be benign. Hepatic adenomas can occur most often in women, and this occurs in the women during their reproductive years more than after reproductive years. So like menopause, perimenopause, you don't see it as much. And if they're taking oral contraceptives, that increases the risk as well. With liver cancer, most of the time it is a metastases. It is not something that is originated in the liver. So primary liver tumors are not common, but most of the time you'll have liver metastases. So if they do catch it in the liver, they will be looking for the origin. They do have non-surgical as well as surgical management. So just with any other type of cancer, you can have radiation chemotherapy, you can do surgery. They try not to do surgical. If it's something that has to do with a metastasis, then they'll talk about non-surgical treatment, palliative care more than anything else. They will have percutaneous biliary drainage systems, and you'll need to monitor for those. If they do want to do surgical management, then they can remove part of the liver if they can leave part that is still functioning. So it just depends on exactly what's going on. What was the cause? Where did it come from? If it's primary and there's still some good tissue left, then they can go in and remove the diseased tissue. And then the liver, the tissue that's good, can still function. It can regenerate as long as everything about it is healthy. Okay. If they require a liver transplant, they will be put on a transplant list. There is strict criteria for liver transplants, transplants in general, but for liver transplants especially, they actually monitor their alcohol level, so they'll have to get blood draws to make sure that they have not consumed alcohol for so many months. And if they are alcoholic, then they talk to them about the fact that they'll never be able to consume alcohol again. And they look at their financial capability, because if you have a transplant, it is expensive to keep up with the medications that they have to take, the immunosuppressants. They have to have long-term treatments, they have to have blood draws, so there's a lot post-op that they still have to keep up with and be able to afford. If they can't afford it, then they might not get the liver. It's going to go to someone who it will most likely benefit. If a patient's going to have a liver transplant, you need to look for signs and symptoms of malnutrition. How bad is their ascites? So do the abdominal girth, fluid and electrolyte disturbances, monitor for those. And all of that needs to be treated prior to surgery, because that's going to increase the likelihood of a successful transplant. So they might get a paracentesis to remove some of that fluid. They might be put on extra diuretics to get rid of that fluid. They'll get IV fluid therapy, electrolyte replacement therapy. They might get magnesium replacement therapy, just to make their body as healthy as possible before the transplant. After the transplant, they'll be put in the ICU initially, and then they'll be moved accordingly based on how they do. But you need to educate pre-op, and then before they go home, educate the family that the home needs to be clean. It's not going to be a sterile environment, but it does need to be clean. They do need to disinfect and keep the home free of bacteria, viruses, fungi, and that includes people coming in to visit. They need to be healthy and no recent illnesses, and not around anyone who has been ill, because then they can be a carrier and still be asymptomatic. The patient will be on a immunosuppressive medication, so they need to be taught about what that means and how that increases the likelihood of them getting an infection that someone else might not get, especially whenever it's viral. Immediately post-op, you're going to look at their cardiovascular status, their respiratory system, make sure that they have a patent airway, they're oxygenating properly, make sure that their kidneys are functioning, especially if they had the general anesthesia. Look at their level of consciousness and make sure they're alert and oriented, that they're not confused. Metabolic functions are going to be monitored as well. You're going to look at their arterial pressure and their MAP. You're going to look at cardiac output, central venous pressure. You're going to get ABGs, they'll be on pulse ox, strict INO. They're going to have frequent heart rate and blood pressure monitoring. They might be on hemodynamic monitoring as well, especially while they're in the ICU. You can check liver function values post-op. You will be doing that as well as electrolyte levels. You're going to be looking at coag profiles, so PT, PTT, INR. They'll have ECG, look at the bile that's coming from the T-tube, make sure that it's still functioning, it's not occluded. They're going to have a JP drain, and all of that needs to be monitored as far as drainage care. A patient will most likely also be on mechanical ventilator, and so they'll need respiratory care management. And that was an example of what they'll look like afterwards with all the drains after they have a liver transplant. Again, they only do liver transplants to people who will have the most success and the best quality of life, just because there are more people that need transplants than there are available donors. And so it's an interesting field to look into if you're interested in working in a transplant, post-transplant unit. You get really familiar with the patients and the families, and then sometimes they just can never have a donor, or they find a donor that is a match, and especially with the liver transplant, they have gone back to using alcohol because they get depressed and they feel like they're never going to get it, so what's the point in stopping? And then they find a donor and they have to be told, no, I'm sorry, because you showed alcohol in your system, you can't get it anyway, and they have a potential of being taken off the donor list. So it's very rewarding, especially the people that are successful and they heal and they do better and they have a productive, amazing, wonderful life. But there's also the parts that are a little bit more sad.